And I'm back. Bones of the pectoral girdle and upper limb. Pectoral girdle, more commonly referred to as the shoulder joint. So the pectoral girdle is the clavicle and the scapula. It supports 30 bones that make up the upper limb. All the components of the appendicular, all are components of the appendicular skeleton. So there's the scapula, there's the clavicle, and then there are the bones of the upper limb. The clavicle or collarbone appears straight when it's viewed anteriorly, looking at it from the front. However, if you hold one in your hand and look at it, it actually is an S-shaped bone when you look at it from either the top or the bottom. It is the only bone of the pectoral girdle that directly attaches with the axial skeleton. It sits between the shoulder and the thoracic cage. It braces and supports the upper limb. The collarbone is a very common injury. Lots of times when people fall on their side or on their shoulder and they come up and they're hurting and they're going like this, and you think, oh, they've separated their shoulder. Many times it's the collarbone that broke. If you are a football fan and a Dallas Cowboy fan, for instance, the reason Dak Prescott became quarterback of the Dallas Cowboys, whatever year ago that was, 5 years ago or so, is because Tony Romo suffered a broken collarbone. And Dak was a rookie, they brought Dak in, and the rest is, as they say, history. The structure enables it to function like a brace in a building that supports two opposing beams. Again, the structure function principle. Each clavicle is distinct and palpable through the skin. The sternal end articulates medially with the manubrium of the collarbone of the sternum. So right in here, you can actually feel that on your own body. The acromial end attaches laterally with the acromion process of the scapula at the acromionavicular joint. The conoid tubercle provides a site for attachment of ligaments near the end. So one part of it's here, the other part of it is right in there. And you can feel this on your own body. But there it is. There's the part that's articulating to the manubrium. There's the part on the scapula. Acromial end, medial end, medium, again, medial for the inside of the body. And there's a posterior view and anterior view. The scapula is a triangular bone that sits on the posterior superior rib cage. Okay, let me start that all over again. It is a triangular bone that sits on the posterior superior rib cage between the second and seventh rib. The body is the largest section. It has three borders: the medial, lateral, and superior, toward the middle, toward the outside, toward the top. Has a coracoid process, which is a hook-shaped projection on the anterior surface. Has a subscapular fossa, which is below the coracoid process. Provides an attachment site for the suprascalis muscle. We will talk about that muscle in chapter 9 and 10 when we start talking about muscles. It also contains the glenoid cavity, which is a shallow indention on its lateral surface, which articulates with the humerus in the shoulder joint. Has a spine, which is a posterior ridge of bone that crosses from medial to lateral, from middle to outside, along the superior scapulae point, terminates at the acromion and acromionavicular joint. Supraspinous fossa, found superior to the spine, and the infraspinous fossa is inferior. So here is the this word right here, infraspinous fossa, supraspinous fossa, the acromion, coracoid process. There's a big picture of the glenoid cavity. There's the lateral border. There's the medial border. There's the body. All right. And again, this is where it is positioned in the body. There, look, that bone right there is the clavicle. There's the scapula. And then there is the humerus. The humerus is the largest and strongest bone in the upper limb. It is the only bone in the arm. Remember, we discussed this in class the other day. that while in general terms we call this structure the arm, clinically or atomically, the arm goes from shoulder to elbow. The clinical term again for the arm is the brachium. Consists of two epiphyses, articulates with other bones, and has a long diaphysis. The proximal epiphyses has a medially oriented ball-shaped humeral head, catches up here, which articulates in the glenoid cavity at the shoulder joint. An anatomical neck is a groove surrounding the head. The neck of a humerus is not as obvious as the neck of the femur, which we will look at here in a little bit. The greater tubercle is a projection of bone lateral to the anatomical neck. It's separated from the smaller medial lesser tubercle by a groove. And this is the place where the tendon of the biceps brachii passes through the groove. The biceps brachii is the big muscle in your arm, and it actually goes from here up to your scapulae. You would think most people think it probably stops in here somewhere. Nope, it goes all the way up into there. The surgical neck is where the proximal epiphyses and the diaphysis meet. The deltoid tubercle is a main feature of the diaphysis. The site for the deltoid muscle. Radial groove on the posterior aspect is the passageway for the radial nerve. And the distal epiphyses, down here, features the medial and lateral epicondyle, which again are attachment sites for muscles. The humerus also has features associated with articulation with the radius and ulna. The capitulum is a spherical knob on the anterior and lateral aspect of the distal epiphysis. The trochlea is a spoon-shaped knob on the anterior and medial aspect of the distal epiphysis. The lateral radial fossa and medial coronoid fossa are small indentions just proximal to the capitulum and the trochlea, and the olecranon fossa is a deep indention on the posterior aspect of the distal epiphyses, and it is a continuation of the trochlea. There's all of those structures. There's the anatomical neck. There's the surgical neck. There's the greater tubercle here. The lesser tubercle is right there. Can't see the lesser tubercle on this view. There is the diaphysis. There's the deltoid tuberosity where the deltoid muscle is going to attach. There is the radial groove for the radial nerve. There's the coronoid and radial fossas, lateral epicondyle, medial epicondyle, the capitulum is that little structure right there, and the trochlea are these two structures covered in hyaline cartilage. If you have that's what I'm looking for the word here, a humerus that you're attempting to, is it right or left, sort of oriented, and you're always going to see the medial epicondyle is going to be the longer side of the bone. Bones of the forearm, again, part of the upper limb that goes from here to here is the forearm. Bones of the forearm are the radius and the ulna. The radius is on the outside, the ulna is on the inside. They're held to one another by the membranous intraosseous membrane. They both articulate with the humerus proximally and with the carpal bones distally. They articulate with one another at both the proximal and distal radio-ulnar joints. The radius is narrow proximally, progressively enlarges distally. In other words, it's narrow on this end and gets bigger as it goes down. The radial head or the proximal epiphysis is the round flattened structure that articulates with the capitulum of the humerus at the elbow joint and the ulna at the proximal radio-ulnar joint. The radial neck is distal to the head, ends at the radial tuberosity on the medial aspect of the radius. And again, this is the attachment site of the biceps brachii muscle. The radius also contains an ulnar notch at the medial aspect, the location of the distal radioulnar joint. The flattened end of the distal epiphysis articulates with the carpal bones at the wrist joint, and the radial styloid processes attached at the tip of the radius forms the lateral boundary of the wrist and provides stability. The ulna is widest at its proximal epiphysis, so it's bigger up here, progressively narrows as it travels distally. Both epiphyses have the following anatomical features. They both have a trochlear notch, articulates with the trochlea. They both have an olecranon, palpable protrusion on the posterior aspect of the trochlear notch. You take your hand, you can feel that palpable structure. Anterior tip of the trochlear notch, the coronoid process, the projection fits into the first coronary fossa. The radial notch of the ulna is lateral to the coronoid process. It is a smooth area that articulates with the radial head. The distal epiphyses has the ulnar head, whose medial side contains the styloid process, and the proximal radius and ulna articulate with the humerus to form the elbow joint. There are the structures. You see the ulna wide at the top, it's narrow at the bottom, and the radius. The way I remember this is if you lay these bones side by side, the ulna is a little bit longer with that little hook-like projection at the top. So I remember that the short word is the longer bone, and the longer bone is the shorter word. But here is the trochlear notch where it fits into the back of the humerus, preventing the elbow from going too far. And again, that's what it looks like from the front, and that's what it looks like from the back. And you see that bone forms the hinge that allows your elbow to do this, but to not go much further than that, because that bone goes into that little depression in that olecranon fossa. Bones of the wrist. There are 8 short bones called carpals, arranged in 2 rows containing 4 bones each. The 4 proximal carpal bones include from lateral to medial. So the first set of 4 from, as you're holding your wrist this way, from outside to inside, are the scaphoid, the lunate, the triquetrum, and the pisiform. The scaphoid is a boat-shaped bone that articulates with the radius. The slightly moon-shaped lunate, that's where it gets its name, articulates primarily with the radius and to a lesser degree with the ulna. The triquetrum is a triangle-shaped bone that articulates with the ulna, and the pisiform is a P-shaped bone that articulates with the triquetrum. When you're looking at your wrist, only 3 of the 8 bones are attached to the radius and ulna. The 4 distal carpal bones included from lateral to medial, the trapezium, the trapezoid, the capitate, and the hamate. The trapezium articulates with the scaphoid. Trapezoid also articulates with the scaphoid. The capitate is rounded, articulates proximally with the scaphoid and lunate, and the hamate is has a hook-like projection that articulates with the triquetrum. So there we go. So we're starting on the outside. There's let me find it. Where's Sally? There's the scaphoid there. There's the lunate, triquetrum, pisiform. There's the trapezium up there. Trapezium, by the thumb side. That just happens to be a right wrist, so you're looking at the hand like this. So you're starting boom, 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 boom. And there's the right wrist, posterior view. Now you're looking at the right wrist this way. So there's the scaphoid, lunate, trapezium, trapezium, trapezoid, capitate, and the hand or the manus is 5 long bones. It's called the metacarpals, numbered 1 through 5, from lateral to medial. They articulate with the distal carpal bones and bones of the fingers. Each metacarpal consists of 3 parts. You have a proximal epiphyses, the diaphysis, and a distal epiphyses. The bones of the fingers consist of 14 phalanges, each with a base, body, and head. Each finger consists of 3 bones, the proximal, the middle, and the distal. And the thumb, or pollex, consists of only proximal and distal phalanxes. So there's, starting with the thumb side, 1, 2, 3, 4, 5. And then there are the 2 bones of that phalange and the 3 bones of all of those phalanges. Wrist fractures. The wrist is one of the most frequently injured regions of the upper limb, usually from direct trauma or an attempt to stop a fall with an outstretched arm. The fracture commonly involves the distal radius and ulna. And you can see the fracture here on this x-ray. Get a better view of it, the way the bone is sort of sticking off. It may also involve the carpal bones, particularly the scaphoid bone. Fracture shown above is a Colles fracture of the distal radius. Again, there is the fracture there. Most common in children and adults ages 60 to 69. The incidence declines with advancing age. The incidence of further fractures such as hip fractures increase, likely because people fail to catch themselves and they land on their hip instead. And as I mentioned the other day, lots of people, most people, as a matter of fact, I know this from my work as an EMT, most people do not break their hip by falling and landing on it. Most people who break their hip actually break their hip and then fall. Symptoms of a wrist fracture: pain and swelling over the affected area with slightly less mobility. Common misconception that if an individual with a fractured bone is still able to move the affected part, will be unable to move. That is not true. You can move your arm if you have a broken arm, unless the bone is dislocated. Then you may be loose. But if you've just got a fracture of a bone, you can still move it. Treatment varies according to the severity of the injury in which the bone is injured. Some treated with simple casting, others will require surgical intervention. Many fractures could be prevented by teaching individuals how to fall in a way that distributes forces across the trunk rather than concentrating on an outstretched arm. This is what Hollywood stuntmen learn how to do. They literally learn how to fall so they don't break things. All right, I'm going to take a break. Talk to you again later.